Thank you, Dr. Umesh. Just when I'm talking, the person who taught me about spherical aberration is here, Dr. Rohit. Thank you. We'll just take a little bit of, he was the one who inspired me to get into this. And it was in 2008 or 9, sorry, slides. ये डाल दिया अच्छा स्लाइड शो ओके I've actually slightly named it right IOL for the right patient how to choose, of course, using the spherical aberrations to our advantage. There are two things we have to look at. Patient might ask for a 1.5 lakhs or 2 lakhs best possible laser refractive surgery, all these things. But what we should look at is his wants versus his needs. I want to make this very short. We are already running short of time. As I told in my previous talk, look at coma as well as spherical aberration. Here we are concentrating on the spherical aberration and look at that in between value between 0.136 to 0.57, approximately 0.6. You can put any kind of advanced IOL the patient will tolerate. Of course, look at all other problems. This is only with spherical aberration. This is a slide. It took some time for Dr. Rohit to teach me. Now, what is a spherical aberration? What are we looking at? The eye is not a perfect sphere, right? So, eye is like a parabola. Now, parabola corresponds to around 0.53, whatever that reading is, 0.53 minus. Now, this is what we take as zero spherical aberration. Where do we look at? Just like what I showed in my previous slide. I have a pentacam. I look at the spherical aberration there. A better thing would be to use an eye tracy like what I said. Anything above 0.6, avoid all advanced IOLs. It's not just the IOL that provides vision to the patient. We have also already in the previous talk, we have emphasized there are a lot of things. One of them happens to be the spherical aberration. And herein, I would like to bring in what Dr. Uday Devgan, I've given the credit to him. This is from his slide. If it is a virgin eye, then all these things will work. If it is already an eye which has undergone LASIK, particularly this prior hyperopic LASIK, never go for this negative spherical aberration lenses. We have used the traditional IOLs, then we came to negative spherical aberration lenses. Do not use it in case of hyperopic LASIK. If you measure the spherical aberration, you will understand why. We'll come to that later. Now, if it is a myopic LASIK, just like how one of my previous speakers, I think Dr. Venkatraman was talking about it, you can use a spherical aberration lens. In case no prior surgery, and then look at IOL decentration, whether there's a chance of IOL decentration, such as pseudo exfoliation or some other thing, then prefer a spherical aberration of 0. There are lenses available, we'll come to that again. Now, if IOL centration is not likely to occur, then you look at the other options that are available, where depth of field, that is multifocality or whatever you call it, or image quality. For this, I have a couple of other slides, we'll go there. Okay, taking it from there, considering this no spherical aberration, what is the right thing for a patient to have? What should we leave it with? Either it can be slightly, human cornea is always positive. That's why we have this lens which is on the negative side, which slightly neutralizes, but as we age, we all know this. That's why we use these negative aspheric lenses. But then how do we calculate this? If the total spherical aberration target is 0.2, what do I mean by this? The corneal spherical aberration added to the spherical aberration that you have with the lenses. Whenever I look at the lens, I don't look at the A constant alone, I look at all these other parameters. I ask the lens manufacturer what the spherical aberration of the lens is. If you get this target, the patient is very happy. Now, I have written on the image quality side. Sorry. Now, if the spherical aberration, total spherical aberration goes beyond this range, that is 0.5, 0.6, this is called toxic. Avoid any of the advanced IOLs in these cases. If it is somewhere in this range, that is prior hyperopic classic, use the traditional spherical IOL, and again if it goes beyond that, this is very rare to get it, then again traditional spherical IOL, but again we want that this patient might need some other corneal procedures. Now what are the two values that we have to take home? One of them I said, if it is image quality what you are concentrating, leave this patient with the spherical aberration of 0.1. That is, you are using a trifocal IOL, you are using some kind of spherical aberration. Look at the cornea, do not go by the company. Look at the cornea, look at the spherical aberration and match it to this. This is what I am doing off late. I have 3 different trifocal IOLs. Now, if it is a depth of focus you are looking at, it's a poor patient who cannot afford. Even with monofocal, you can give some kind of depth to this patient. This is what all these enhanced monofocals are doing. So look at the value of final 0.3. So how do we calculate this? Sorry. Yeah. These are the options available in my clinic. It could be a 0 spherical aberration, positive spherical aberration, 0 spherical aberration, minus of 0.19 or 0.2, and the highest what we are getting as of date to the best of my knowledge is minus 0.27. I am not talking about the brand of the IOLs, obvious reasons. You know what 0.27 is, what 0.2 is. There is one at 0.18, there are certain at 0. So look at the corneal aberration, add it to these values, and if you are looking at good quality of vision, target should be, this addition should land at 0.1. If you are using a monofocal IOL and you want to give some kind of multifocality to this patient, target 0.3. Simple mathematics, but you need a pentacam, or I use a pentacam, but better would be an eye tracy. Eye tracy is obviously the best, I don't have it. Now, we have various occupations who may require intermediate, but this said and done, whatever, when you calculate the spherical aberration, this is only for intermediate distance. Near vision, again need for glasses. Anyway, I don't assure this patient's freedom from glasses. The monofocal IOLs where I do these changes, I don't assure them, but definitely many of them are doing well. Even the well established who go for monofocal, there are a lot of hobbies that need near vision. This is a similar graph which was projected by Dr. Kumaran. Anyway, each lens has its own. Summing up, we are running out of time. I am slightly fast forwarding my slides. Look at wants versus needs. Rule out all other pathologies. If there's a pathology and you put an advanced IOL, this patient is not going to be happy. Look at the non-dominant eye. That's where you do okay. With all this spherical aberration, you still need to do a little bit of an offset. Non-dominant eye, do a little bit of offset. Rule out aberrations. Communicate to this patient. Always you will be a happy 20 by happy patient. At the end, thank you. Thank you, Dr. Rohit, for teaching also. I like to thank Dr. Amrita Sharma and then all our esteemed delegates here who attended this despite having it at 8 o'clock in the morning. Thanks a lot, sirs.
Wonderful lecture, so wonderful. It was really a learning experience for us.